Hello everyone, my name is Shadi Afini from Johns Hopkins University, and it's my pleasure to present on behalf of my co-authors. In this video abstract, I'd like to briefly take you through our article entitled Role of Diagnostic Radiology in the Management of Intrahepatic Cholangiocarcinoma. We all know intrahepatic cholangiocarcinoma is a rare and aggressive liver cancer, and the incidence is increasing. The prognosis of ICC is generally poor, with a 5-year survival rate of around 10 to 15%. Early diagnosis and treatment are crucial for improved outcome, but early diagnosis is challenging due to the lack of specific symptom and biomarkers. Let's start with the role of radiology in diagnosis. Imaging modalities such as ultrasound, CT, MRI, and PET are commonly used to identify and characterize liver lesions. Differentiating ICC from other liver cancers, such as hepatocellular carcinoma and combined hepatocellular cholangiocarcinoma, can be challenging due to overlapping features and nonspecific clinical presentation. MRI is generally considered superior to CT and ultrasound in diagnosing focal liver lesions, since we can evaluate different imaging sequences and functional data using MRI. For example, DWI has shown promise in distinguishing ICC from HCC. In addition, contrast-enhanced imaging techniques such as multi-phase contrast-enhanced CT and dynamic contrast-enhanced MRI have improved the visualization of tumor vascularity and aid in characterization and differentiation of ICC from other hepatic malignancies. Hepatocyte-specific contrast agents like AOVs have shown efficacy in identifying and characterizing hepatic lesions by providing a clear contrast between the tumor and liver tissue. The hepatobiliary phase imaging using AOVs helps differentiate ICC from other liver lesions, assess tumor size, and identify satellite lesions. Here we have some MR images of a 57-year-old patient. The images A and B are hepatoarterial and portal venous phase images, and we can see a hypoinduced large mass with capsular retraction and also progressive central enhancement on portal venous phase, which are typical MRI findings of ICC. This mass has heterogeneous high signal intensity in T2 sequence in image C. Always enhanced MR image in image D shows rim enhancing centrally necrotic mass. DWI in image E demonstrates that the tumor restricts diffusion with a heterogeneous peripheral increased signal. And finally, ADC map in image F shows a low ADC value in the rim area and a heterogeneous higher ADC value in the center of the lesion. Next section of our article is about the role of diagnostic radiology in the staging. In the case of resectable ICC, different staging methods are used to estimate the prognosis. The American Joint Committee on Cancer Staging System, based on tumor, node, and metastasis classification, is commonly used but has limitations for unresectable tumors. Alternative prognostic models, such as nomogram, have been developed to improve outcome prediction by considering factors like biochemical markers, imaging features, and pathologic parameters. However, these models lack functional information and are based on biopsy or surgery, which makes them unsuitable for unresectable ICC patients. For unresectable ICC, which represents a significant portion of cases due to delayed diagnosis and combined conditions, there are challenges in tumor staging and monitoring treatment response. The food and scoring system has been developed as a prediction model for unresectable ICC using clinical data obtained through imaging and biochemical blood tests. However, the subjective assessment of tumor margins and ignorance of lymph node status are limitations of this model. Lymph node involvement and microvascular invasion are important predictors of prognosis in ICC. MBI, which currently can only be identified through postoperative pathology, is crucial to predict before surgery. According to recent studies, diffusion restriction and ADC value on MRI have been associated with MBI, and certain MRI quantitative features have been used to evaluate MBI. Lymph node metastasis is another critical predictor of outcome. and preoperative imaging methods such as CT and MRI have limitations in accurately detecting lymph node metastases, particularly for certain ICC subtypes. The ADC value of the primary ICC lesion, along with diameter of the largest lymph node, has shown promise in preoperative detection of lymph node metastases. PET-CT and PET-MRI have demonstrated advantages in detecting ICC, assessing metabolic activity, nodal staging, and identifying distant metastases. SUV max values obtained from PET have been associated with overall survival and recurrence. Novel ligands such as fibroblast activation protein inhibitor tagged to PET resort show potential for improved imaging and staging of ICC, but further research is needed to establish their role. Next part of our article is explaining about the role of diagnostic radiology in the monitoring the treatment. Conventional tumor response criteria such as WHO, RECIST, EMRECIST, and European Association for the Study of Liver criteria rely on changes in tumor size or enhancement to assess response, but they have limitations in reliability and reproducibility. The hypovascular nature and fibrous stroma of ICC make it challenging to apply these criteria accurately. Functional MRI techniques, including multiparametric MRI and T2-weighted imaging, dynamic contrast-enhanced MRI, and spectroscopic imaging, provide more sensitive and accurate assessment of cellular changes throughout treatment. DWI, ADC-MAP, and DCA-MRI can detect early cellular changes and provide information on treatment response. Poor ADC values indicate a highly cellular tumor with restricted water molecule mobility, while increased ADC values suggest cellular necrosis and damage. EWI doesn't require contrast material administration, making it suitable for patients with kidney disease or contrast material allergies. In monitoring the response to transarterial chemoembolization, volumetric changes in ADC and contrast-enhanced on MRI have been associated with favorable response to therapy and improved survival. Baseline ADC values and certain characteristics observed in baseline MRI scans, such as viable tumor volume and necrosis, can serve as predictor of survival rate in ICC patients undergoing TACE. For monitoring the response to transarterial radioembolization, radiomics-based quantitative features obtained from baseline CT scan can help identify ICC patients most likely to respond well to the treatment. Dosimetry, the measurement of radiation dose, is an important aspect of TER, and interprocedural MRI-based dosimetry has shown promise in providing real-time insight into microsphere distribution during TER. In the context of immunotherapy, MRI quantitative features have been explored for predicting immunophenotyping and outcome in ICC patients. Pre-treatment MRI features such as ADC value have been associated with early progression of unresectable ICC with systemic therapy. Thank you.